Good morning, everyone. I'm going to be talking about this challenge we all face every day in the emergency department and in our intensive care unit, and that's deciding whether to give this patient broad-spectrum antibiotics up front versus whether we should wait a little bit, do some more diagnostic evaluation to confirm or refute the likelihood that this patient has infection, or to clarify which antibiotics they need. I'm going to start with my take-home points. The first is that our current guidelines and quality improvement initiatives rigidly dichotomize or hinge around this diagnosis of sepsis. But we actually know that the benefit of earlier antibiotics varies widely across patients, even among our patients with sepsis. Secondly, we know that diagnostic uncertainty is common, particularly early on in a patient's clinical course. It's hard to know with certainty whether their illness is due to infection or due to another cause. And so I'm going to make the case over the next 15 minutes about why risk-based bedside management could be a better option. So time to antibiotics and sepsis. This has been a very hot topic over the past couple years and has also been fairly polarizing for the critical care field. On the one hand, we have people who think that earlier antibiotics are vital. This is the most important lever by which we have to reduce sepsis-related mortality. And people in this camp are likely to cite recent large observational studies showing that with each hour in delay in time to antibiotics, there's increase in hospital mortality. But on the other side, we have people who think that this current intensive focus on earlier antibiotics is potentially harmful, driving up unnecessary antibiotic use with their associated harms and antimicrobial resistance. And people in this camp might cite the Fantasy trial. This was a study that randomized people to antibiotics in the ambulance en route to the hospital. On average, patients in the treatment arm got antibiotics about 90 minutes sooner, and yet there was no difference in mortality between the study arms. And so people say, aha, it doesn't really matter how quickly we get antibiotics. This is overblown. So how do we reconcile these potentially conflicting studies, and how do we reconcile these potentially conflicting viewpoints? At this point, I'm sorry, I'm going to go through a little bit of math, but it's important to remember that the effect of any treatment is highly variable across patients. So for any given condition or diagnosis, there's a range of illness severity, even among patients with sepsis or at risk for sepsis. So we have patients who are very sick, who are very high risk of having a poor outcome, but we also have patients who are less ill and at much lower risk of a poor outcome. In general, when we provide a treatment to patients, this confers a relative risk reduction, such that the highest risk patients derive the greatest benefit, and people who are unlikely to have the bad outcome in the first place can only derive so much benefit from treatment. By contrast, however, typically the harms or the risks of treatment are conferred equally across patients. And so when we combine the baseline risk, this relative risk reduction with a treatment, the harms of treatment, we're typically left that we have patients that fall into three broad buckets. We have people for whom the treatment is clearly beneficial. We have patients for whom it's equivocal. And then we have patients that were at such low risk of having a bad outcome that they're really only exposed to the potential harms of treatment. And when we have this situation where there's this range in the absolute or net benefit of treatment, we can get conflicting results of studies. So in this example, we have a therapy, and it's being studied simultaneously in two different studies. Study 1, however, disproportionately enrolls sicker patients. And study 2 has the same inclusions and the same exclusions, but it just tends to actually enroll a less sick population. And in this sort of a scenario, even though the therapy might provide the same relative risk reduction, we're going to get conflicting results. So we have study 1 being positive. We can measure a benefit of the treatment. And in study 2, negative. We can't detect a benefit of this therapy. And while there are many differences between the various time to antibiotic studies, I actually think this is the most critical point here, is the differences in the patients who are being included in these studies. So in the Seymour study, this large observational study out of New York, there was 45% of the patients with septic shock, 25% in hospital mortality, And when we look at the fantasy trial, 4% septic shock, 8% 28-day mortality, these were very different patients. And when you do some back-of-the-envelope calculations, you actually find the relative reduction is essentially the same in these two studies. So I don't think there's as much conflict as we think. I think there's a consistent message, and that's that the benefit of earlier antibiotics really varies depending on who the patient is in front of us. The second point I want to make is that diagnostic uncertainty is common. We don't know with certainty who has sepsis when they first show up to see us. We know this from vignette studies. So when we give cases, standardized cases to clinicians, and we say, is this severe sepsis? Is this septic shock? Or is there a non-infectious cause for their illness? Consistently, we see the clinicians do not agree. We see the same thing in cohort studies. So when we look at populations of patients who are admitted to an ICU with a diagnosis of sepsis, and then we ask clinicians at the very end of their hospital stay, how likely was it that they really did have sepsis when they came into our ICU? About 13% of the time they say no chance. Given the additional studies and workup and things we found out later on down the road, there was no chance this was sepsis. And about 30% of the time they say, well, maybe it was possible, but certainly not likely and not definite. So about 43% of the time, not possible or not likely that the patient who we thought was septic in the beginning turns out to be septic at the end. And nonetheless, our guidelines and our quality improvement initiatives consistently assume this unambiguous diagnosis. If the patient has sepsis, give antibiotics in 1 hour. When we assess clinicians and we assess hospitals and how well they do at treating patients with sepsis, we look at patients who are diagnosed with sepsis at the very end of the hospital stay and say, well, did you give antibiotics at the very beginning of this hospitalization at the appropriate time target? And the question is, can we do better? Can we align our guidelines? Can we align our performance assessment and our quality improvement to better align with this bedside reality where we don't know with certainty? And I think that we can. And the idea would be to have a framework with two axes. One, the most important axis, is how sick is that patient when they show up to see you? And the second is, how likely is this to be due to infection? So what does this mean? What would this look like? For the patient who shows up very sick with clear signs and symptoms of infection, we all know what to do. This patient should get antibiotics immediately. And when we look at the distribution of time to antibiotics for patients in this bucket, it should be quick. The vast majority of these patients should be getting antibiotics early, within an hour. And on the flip side, the patient who shows up who's not that sick, no real clear signs or symptoms of infection, these patients should not get antibiotics up front. Very few of them should ever get antibiotics, and they should only get them after additional diagnostic evaluation tells us that, well, even though it didn't seem likely, they didn't have real signs or symptoms, in fact, we find out that they do. And so our distribution of time to antibiotics might look something like this. A smaller bump, smaller number of people treated, and only much later, after the diagnostic evaluation tells us, oh no, there is infection and we should treat this. The next population I'm going to talk about are the patients who, again, not as sick, indeterminate probability of infection. These are perhaps the population of patients that is the focus of our antimicrobial stewards. And these patients could be somewhere in the middle. Again, more of them will need antibiotics because infection is more likely, and more of them will turn out to be infected. But again, they're not that sick. We have time to clarify, to confirm or refute this suspicion that infection is present. But I think the population for whom this framework is potentially most paradigm shifting is these people down here who show up very sick. They don't have signs or symptoms of infection, but you don't know what's going on. So we see these patients all the time. This is someone who's, comes in and they're confused, they're somnolent, they're obtunded. You can't get a good story. Family doesn't remember any kind of infectious symptoms. They don't have a fever, they don't have a white count, but they're sick. They have organ failure, and we don't know why. These patients are too sick to guess wrong. These are the patients that we also need to treat with antibiotics up front, but recognize we're doing that not because we have we know that they have sepsis, but because they're too sick to guess wrong, and they need additional diagnostic workup after the antibiotics. And so these people might look something like this. They're going to get antibiotics quicker, but maybe not all of them, because some of these patients, you're going to have a better alternative explanation. You're going to say, oh, actually, I knew that they were hit by a car crossing the street, or they had a witnessed overdose. And if we have a clear explanation for another cause, then that's OK. But many of these patients, we don't. And if we don't think about the antibiotics up front, we might miss the boat. And these are the patients for whom time to antibiotics is critical. In contrast, however, to this sort of envisioned world where we treat people based on their risks, currently, time to antibiotics is basically the same across patients regardless of illness severity. And similarly, the broadness of the initial antibiotic spectrum is quite similar across patients on average, regardless of illness severity. So is it possible? Can we do this? I'm going to make two arguments for why I think that such an approach would be feasible. The first is that we currently do this for a lot of conditions in medicine, right? So for a patient with atrial fibrillation, we decide whether they should have anticoagulation based on their risk of having a stroke. And we decide whether to start a patient on a statin, not based on a cholesterol target per se, but on their risk of having a cardiovascular event in the next 10 years. And we decide on a hemoglobin A1C target based on their risk of diabetic complications. So other fields, other conditions, we've already incorporated this risk of bad outcome into our treatment algorithms. The second reason I think that this is possible, and this is really important, it's because even blunt risk tools work. So they don't have to be perfect, right? We have good tools to tell us how sick is this patient, but our tools to say how likely is it infection are not as well developed. But they don't have to be. We don't have to let perfect be the enemy of good. So I'm going to tell a quick story. John Spurtis is a cardiologist in the United States, and he studies bleeding after heart catheterization. And he finds that the use of bleeding mitigation strategies is variable across patients, and there's very little correlation between risk and the delivery of these bleeding mitigation strategies. So low-risk patients are getting expensive bleeding avoidance strategies, and high-risk patients are going without them. And so he tried to solve this problem, and he used a simplistic risk prediction algorithm, took into account 8 or 9 clinical variables, and he simply told clinicians at the time of heart cath, this patient is low, medium, or high risk for post-cath bleeding. And just this simplistic bucketing patients into low, medium, or high risk was enough to preferentially nudge physicians to increase the delivery of the bleeding avoidance strategies to the highest risk patients and overall reduced the odds of bleeding 44% across the patients in this study. So even relatively simple tools that take into account a variety of risk factors can nudge us in the right direction. So in sum, I think that we should be asking, given the situation at hand when the patient shows up, was the urgency of treatment appropriate? Are the sicker patients getting antibiotics up front, but the less sick patients getting additional diagnostic evaluation first? And secondly, as the situation evolved, was the treatment plan updated accordingly? We know that part of good care involves giving broad-spectrum antibiotics to patients who ultimately are found to have a non-infectious cause for their shock. And when that comes to be seen, do we stop those antibiotics as soon as that information is available? I'd like to thank you all for your attention. I'd also, if you're interested in seeing a written version of this talk, this perspective is being simultaneously released in Annals of American Thoracic Society. Thank you, everyone.